Proprioceptive neuromuscular facilitation. PNF is divided into two areas, strengthening and stretching techniques and patterning. The ultimate goal is to improve movement patterns, so progressing from basic stretching and strengthening to patterns is very important. Establishing proper mobility of a joint and the muscles must occur prior to strengthening the movement and/or patterns in order to create effective neuromuscular facilitation. Ensuring that the mobility is sufficient will allow more efficient transition into functional training. If the mobility is not reestablished, movement compensations may arise during functional training. However, certain strengthening techniques are recommended under therapeutic conditions in order to sustain and influence muscle contractions. PNF is based on principles of functional anatomy and neurophysiology. It uses proprioceptive, cutaneous, and auditory input to produce functional improvements in motor output and can be important during the rehabilitation process. Clinically, PNF is utilized to increase strength, range of motion, and neuromuscular control. Let's start with PNF to improve strength and neuromuscular control. These techniques were first attributed to work with patients with paralysis and neuromuscular disorders in the 1950s. Originally, PNF techniques were used for strengthening and enhancing neuromuscular control. Since the early 1970s, PNF techniques have been used as techniques to increase flexibility and range of motion. Facilitation and inhibition were first described by Sherrington in early works. According to Sherrington, an impulse traveling down the corticospinal tract or an afferent impulse traveling up from the peripheral receptors into the muscle causes an impulse volley that results in the discharge of a limited number of specific motor neurons, as well as the discharge of additional surrounding, anatomically close motor neurons in the subliminal fringe area. An impulse causing the recruitment and the discharge of additional motor neurons within the subliminal fringe is said to be facilitatory. Any stimulus that causes motor neurons to drop out of the discharge zone and away from the subliminal fringe is said to be inhibitory. Facilitation results in an increased excitability, and inhibition results in decreased excitability of the motor neurons. The function of weak muscles would be aided by facilitation, and muscle spasticity would be decreased by inhibition. Sherrington attributed the impulses transmitted from the peripheral stretch receptors via the afferent system as being the strongest influence on the alpha motor neurons. Therefore, as a clinician, we can influence the excitability of the alpha motor neurons. The discharge of the motor neurons can be facilitated by peripheral stimulation, causing afferent impulses to contact excitatory neurons and results in increased muscle tone or strength of voluntary contractions. Motor neurons can be inhibited by peripheral stimulation, which causes afferent impulses to contact inhibitory neurons, resulting in muscle relaxation and allowing for the stretch of a muscle. Excitation or inhibition of motor neurons will be dependent on the ratio of incoming impulses. There are several approaches to the principles of facilitation and inhibition that have been proposed, although the method proposed by Knott and Voss is the one that is most explicitly used to describe PNF. Using PNF clinically, we should focus on what the patient can do physically within the limitations of the injury. We can use PNF to address deficiencies in strength, flexibility, and neuromuscular coordination. We emphasize selective re-education of individual motor elements and work to develop neuromuscular control, joint stability, and coordinated mobility. Each movement should be learned and then is reinforced through repetition. Our bodies respond to the demands that we place on it or that are placed upon it. PNF attempts to provide maximal response for increasing strength and neuromuscular control. During the rehabilitation protocol, it is important to evaluate the program intensity, our patient's goals, and their stage of healing when implementing PNF stretching or strengthening protocols. The approach to proprioceptive neuromuscular facilitation is holistic as it integrates sensory, motor, and psychological aspects of a rehabilitation program. The reflex activities come from the spinal level and upward, either inhibiting or facilitating them as appropriate. The brain recognizes gross joint movements, but not individual muscle actions. The strength of a muscle contraction is proportional to the activated motor unit recruited. To increase the strength of a muscle, the maximum number of motor units must be stimulated to strengthen the remaining muscle fibers. This overflow or irradiation effect can occur when stronger muscle groups help the weaker groups in completing a particular movement. This cooperation leads to the rehab goal of returning to optimal function. The principles of PNF are based on sound neurophysiologic and kinesiologic principles and clinical experience and should be applied to all forms of PNF rather than specific techniques of PNF. The application of these principles can help to promote the desired response. First, the patient must be taught sequential movement patterns from a starting position to a terminal position. Instruction should be brief and should be using simple words. Sometimes it is helpful to demonstrate the motion and move the patient passively through the desired motion. We may provide aid to the movement if needed as well. The patterns for PNF can be used in conjunction with different techniques to increase the effects of the PNF treatment. Having the patient look at the extremity as it is moving through the movement can potentially aid in teaching the desired movements as well. Having patients utilize visual stimulus or feedback to acquire directional and positional control can be very helpful. Verbal cues are critical. They are used to coordinate voluntary effort with reflex responses. Commands commonly used with PNF techniques are push and pull, which asks for an isotonic contraction, hold, which asks for an isometric or stabilizing contraction, and relax. Manual contact with the appropriate pressure is essential for influencing the direction of motion and facilitating maximum response of the reflex response. The reflex response is altered by pressure receptors, so the way we touch the patient influences the patient's confidence as well as the appropriateness of the response. Movement may be facilitated by touching over a muscle to facilitate a contraction or a stabilization. Contact should be firm and professional at all times. Proper mechanics and body positioning for the clinician and the patient are critical for the effective pressure and resistance during treatment. The amount of resistance given should facilitate a maximal response that allows for smooth, coordinated motions. The appropriate resistance will be dependent upon the patient's capabilities. It may also change during different points in the range of motion. Maximal resistance may be applied with techniques that use isometric contractions to restrict motion at specific points. It may also be used during isotonic contractions throughout the full range of motion. Rotational movement is a critical component in all PNF patterns because maximal contraction is impossible without it. The timing of muscle sequential firing. Normal timing is a sequence of muscle contractions that occur in any motor activity, resulting in coordinated movement. Distal movements of the pattern should occur first and should be completed no later than halfway through the total PNF pattern. The timing for emphasis is used primarily with isotonic contractions. This principle superimposes maximal resistance at specific points in the range of motion to facilitate overflow or irradiation. The stronger components are emphasized to facilitate the weaker components of a movement pattern. Specific joints may be facilitated by using traction or approximation to facilitate the process. Traction spreads apart the joint articulation, and approximation presses them together. The two techniques stimulate the joint proprioceptors. Traction increases the muscular response, promotes movement, assists with isotonic contractions, and is used with most flexion anti-gravity movements. Approximation increases the muscular response, promotes stability, assists with isometric contractions, and is used most with extension, gravity-assisted movements. The utilization of quick stretch facilitates muscle responses and allows the muscle to respond with greater force throughout the stretch reflex. It is most effective if all of the components of movement are stretched simultaneously. Please be aware of contraindications. Stretching orthopedic conditions can result in increased damage to the musculotendinous unit or the joint structure, so we need to be sure that our patient is in the proper stage of healing prior to implementing these techniques. PNF strengthening techniques. These techniques can be utilized in a rehabilitation program to promote strength developments. We will touch on the different PNF strengthening techniques. Rhythmic initiation. This technique involves a progression of the initial passive motion, followed by active assistive, and active movement against resistance through the agonist pattern. Slow movement is utilized throughout the available range of motion. It also avoids activation of a quick stretch response. This technique is utilized for patients who are unable to initiate movement and for patients who have a limited range of motion because of increased tone. It can also be utilized to teach movement patterns. We typically use this early in the rehabilitation process to initiate movement when the patient is having difficulty moving actively through a pain-free arc. The passive movement can allow the patient to maintain full range while using an active contraction to move through the available pain-free range of motion. Repeated contraction. This technique is useful for treating weakness at specific points or throughout an entire range of motion. It is used to correct imbalances that occur in the range of motion by repeating the weakest portion of the total range. The patient moves isotonically against maximal resistance repeatedly until fatigue is evidenced in the weaker components of the muscle. When fatigue of the weak components becomes apparent, a period of stretching in the range should facilitate the weaker muscle and results in a smoother, more coordinated movement. Resistance and stretch must be modified for each athlete and the relative strength of the muscle group. Slow reversal. This involves an isotonic contraction of the agonist muscle, followed immediately by an isotonic contraction of the antagonist. The initial contraction of the agonist muscle group facilitates the succeeding contraction of the antagonist muscle. The slow reversal technique can be used to develop active range of motion of the agonist and normal reciprocal timing between the antagonist and the agonist, which is critical for coordinated movement. This technique helps to improve muscle endurance. The patient should be commanded to push against maximal resistance by using the antagonist and then pull by using the agonist. The initial agonist push facilitates the succeeding antagonist contraction. Slow reversal hold is an agonist isotonic contraction, followed immediately by an isometric contraction, with a hold command given at the end of each of the active movement. The direction of the pattern is reversed by using the same sequence of contraction with no relaxation before shifting to the antagonistic pattern. We then alternate with an antagonist and agonist activity. This technique can be useful to develop strength at specific points in the range of motion. It can also be used to correct weaknesses at certain points in the range through isometric strengthening. Rhythmic stabilization uses an isometric contraction of the agonist, followed by an isometric contraction of the antagonist to produce co-contraction and stability of the two opposing muscle groups, resisting motion. The command given is to maintain the hold position while movement is applied in multiple directions. Rhythmic stabilization results in an increase in the holding power to a point where the position cannot be broken. Holding should emphasize co-contraction of the agonist and the antagonist. This technique is utilized to develop neuromuscular control and stability. Rhythmic stabilization requires co-contraction of opposing muscle groups and is helpful to create balance in the existing force couples. PNF strengthening techniques can be useful in a variety of different conditions. The technique is often dictated by a patient's condition and the capabilities of the individual. Also think about the limitations of the individual patient. Relative to other strengthening protocols, PNF techniques do not require the use of commercial exercise machines. PNF is not cumbersome, and the patient may even be able to perform some of the activities on themselves. PNF training can emphasize triplanar motion that many exercise machines lack. Movement can occur in 3 planes simultaneously, thus is more closely resembling a functional movement pattern. The clinician can alter the resistance and the range of motion, depending on the individual need of the patient. Resistance can also be altered throughout the range of motion to meet the patient's capabilities. And combinations of several strengthening techniques can be used concurrently within the same PNF pattern. There are also PNF patterns, which include the three-dimensional movement and mimics activities of daily living. These PNF patterns can be combined with the different PNF strengthening techniques during the rehabilitation process as well. The PNF patterns are concerned with gross movements and not specific muscle actions. These movements incorporate rotational and diagonal patterns similar to motions required in sports and daily activities. The exercise patterns have 3 movement components: flexion-extension, abduction and adduction, and internal and external rotation. Human movement is patterned and rarely involves straight motion, because all muscles are spiral in nature and lie in a diagonal direction. Distinct diagonal and rotational patterns of the upper and lower extremity, along with the upper and lower trunk and neck, exist in PNF patterns. This exercise pattern is initiated with the muscle groups in a lengthened or stretched position. The muscle group is then contracted, moving the body part through the range of motion to a shortened position. The upper and the lower extremities all have two separate patterns of diagonal movement for each part of the body, which are referred to as the diagonal 1 or D1 and the diagonal 2 or D2 pattern. These diagonal patterns are subdivided into D1 moving into flexion, D1 moving into extension, D2 moving into flexion, and D2 moving into extension. The patterns are named according to the proximal pivots at either the shoulder or the hip. This is the D1 pattern for upper extremity. We will practice this in class. On this slide, we can see both the flexion and the extension. We can also see the individual body parts, including the shoulder, scapula, forearm, wrist, finger and thumb, and hand position for the athletic trainer or the clinician. We can also see the verbal commands that we should be saying during this movement. This is the D2 pattern for the upper extremity. Again, we have D2 for flexion and D2 moving into extension. We also have patterns for the lower extremity. This is the D1 pattern for the lower extremity. We can see D1 moving into flexion and D1 moving into extension for the lower extremity. Here is the D2 pattern for the lower extremity. Again, D2 moving into flexion and D2 moving into extension for the lower extremity. This is the pattern for upper trunk movement. We can see a pattern for flexion and a pattern for extension. This is the pattern for lower extremity rotation, both for flexion and extension. And finally, here are the neck patterns, both flexion and extension. As indicated previously, PNF techniques can also be used for stretching to increase range of motion. PNF stretching can be an effective treatment modality for improving flexibility and is often used in clinical practice. Various theories have been proposed to explain the neurologic and physical mechanisms through which the PNF techniques improve flexibility. PNF gained popularity as a stretching technique in the 1970s. The stretch reflex will help us to understand the currently accepted theory associated with PNF stretching. The stretch reflex involves two types of receptors: muscle spindles that are sensitive to length changes and the rate of length change, and the Golgi tendon organs, or the GTOs, that detect changes in tension. Stretching a given muscle causes an increase in the frequency of impulses transmitted to the spinal cord from the muscle spindles along the 1A fibers, which produce an increase in the frequency of motor nerve impulses returning to that same muscle along the alpha motor neurons, thus reflexively resisting the stretch. The development of excessive tension within the muscle activates the Golgi tendon organ, whose sensory impulses are carried back to the spinal cord along the 1B fibers. These impulses have an inhibitory effect on the motor impulses returning to the muscles and cause that muscle to relax. The stretch reflex is also called the myotatic reflex. This is also known as the knee-jerk reflex or a deep tendon reflex. This is a pre-programmed response by the body to a stretch stimulus in the muscle. When a muscle spindle is stretched, an impulse is immediately sent to the spinal cord, and a response to contract the muscle is received. Since the impulse only has to go to the spinal cord and back, not all the way to the brain, it is a very quick impulse. It generally occurs in 1 to 2 milliseconds. This is designed as a protective measure for the muscles to prevent tearing. The muscle spindle is stretched, and the impulse is also immediately received to contract the muscle, protecting it from being pulled forcefully or beyond a normal range. The synergistic muscles, those that produce the same movement, are also innervated when the stretch reflex is activated. This further strengthens the contraction and prevents injury. At the same time, the stretch reflex has an inhibitory aspect to the antagonistic muscle. When the stretch reflex is activated, the impulse is sent from the stretched muscle spindle, and the motor neuron is split so that the signal to contract can be sent to the stretched muscle, while a signal to relax can be sent to the antagonist muscle. Without this inhibitory action, as soon as the stretched muscle began to contract, the antagonist muscle would be stretched, causing a stretch reflex in that one. Both muscles would then end up contracting simultaneously. The stretch reflex is very important in posture. It helps us to maintain proper posture because a slight lean to either side can cause a stretch in the spinal, hip, and leg muscles to the other side, which is quickly countered by the stretch reflex. This is a consistent process of adjusting and maintaining. The body is constantly under push and pull forces from the outside, one of which is the force of gravity. Another example of the stretch reflex is the knee jerk test performed by physicians. When the patellar tendon is tapped with a small hammer or reflex hammer, it causes a slight stretch in the tendon, and consequently, the quadricep muscle contracts. The result is a quick, although mild, contraction of the quadricep muscles, resulting in a small kicking motion. Two neurophysiological phenomena have been proposed to explain facilitation and inhibition of the neuromuscular systems. The first, autogenic inhibition, is defined as inhibition mediated by afferent fibers of a stretched muscle, acting on the alpha motor neurons supplying that muscle, causing it to relax. When the muscle is stretched, motor neurons supplying that muscle receive both excitatory and inhibitory impulses from the receptors. If the stretch is continued for a slightly extended time, the inhibitory signals from the Golgi tendon organ, or GTOs, eventually override the excitatory impulses and therefore cause relaxation. Inhibitory muscle neurons receive impulses from the Golgi tendon organs, while the muscle spindles create an initial reflex excitation, leading to contraction. The GTOs, or Golgi tendon organs, apparently send inhibitory impulses that last for the duration of the increased tension, resulting from either passive stretch or active contraction, and eventually dominate the weaker impulses from the muscle spindle. This inhibition seems to protect the muscle against injury from reflex contractions, resulting from excessive stretching. A second mechanism, reciprocal inhibition, deals with the relationship of the agonist and the antagonist muscle. The muscles that contract to produce joint motion are referred to as the agonist, and the resulting movement is called an agonist pattern. The muscles that stretch to allow the agonist pattern to occur are referred to as antagonists. Movements that occur directly opposite to the agonist pattern is called the antagonist pattern. When motor neurons of the agonist muscle receive excitatory impulses from afferent nerves, the motor neurons that supply the antagonist muscle are inhibited by afferent impulses. Contraction or extended stretch of the agonist muscle has been said to elicit relaxation or inhibit the antagonist. A quick stretch of the antagonist muscle facilitates a contraction of the agonist muscle. There is limited evidence that supports the role of the stretch reflex involvement in PNF. Other mechanisms have therefore been proposed. One of those mechanisms is the presynaptic inhibition. In the PNF stretching techniques, the contraction and subsequent relaxation of the target muscle is followed by a slow passive stretch of that muscle to a longer length. It has been suggested that lengthening is associated with an increase in presynaptic inhibition of the sensory signal from the muscle spindle. This occurs with inhibition of the release of a neurotransmitter from the synaptic terminals of the muscle spindle 1A sensory fibers that limit its activation in the muscle. There are also viscoelastic changes that occur in the muscle in response to stretching. The force that is required to produce a change in the length of a muscle is determined by its elastic stiffness. Because of the viscous properties of muscle, less force is needed to elongate a muscle if that force is applied slowly rather than rapidly. Also, the force that resists elongation is reduced if the muscle is held at a stretched length over a period of time, thus producing stress relaxation. As stress relaxation occurs, the muscle will elongate, further producing creep. As viscoelastic properties change during PNF stretching, there is an altered perception of stretch and a greater range of motion, and greater torque can be achieved before the onset of pain. This is thought to occur because lengthening interrupts the actin-myosin bonds within the interfusal fibers of the muscle spindle, thus reducing their sensitivity to stretch. The following techniques should be used to increase range of motion, relaxation, and inhibition. Contract-relax is a stretching technique that moves body parts passively into the agonist pattern. The patient is instructed to push by contracting the antagonist muscle, the muscle that will be stretched, isotonically against the resistance of the clinician. The patient then relaxes, and the clinician takes the muscle through as much of that range of motion as is possible to the point where limitation is felt. This is useful when the range of motion is limited by muscle tightness. Hold relax is very similar to the contract relax technique. It begins with an isometric contraction of the antagonist, the muscle that will be stretched, against resistance, followed by a concentric contraction of the agonist combined with light pressure from the clinician to produce a maximal stretch of the antagonist. This technique is appropriate when there is muscle tension on one side of a joint and may be used with either the agonist or the antagonist muscle. Slow reversal hold technique begins with an isotonic contraction of the agonist, which often limits the range of motion in the agonist pattern, followed by an isometric contraction of the antagonist, the muscle that will be stretched during the push phase. During the relaxation phase, the antagonists are relaxed while the agonists are contracting, causing movement in the direction of the agonist pattern, and thus stretching the antagonist muscles. The technique, like contract relax and hold relax, is useful for increasing range of motion when the primary limiting factor is the antagonistic muscle group. Since the goal of rehabilitation for most injuries is the restoration of strength throughout the full, non-restricted range of motion, several of these techniques are often combined to accomplish this goal.